drugs, or ideas, what you consume influences who you become. On the Mind and Matter podcast, we learn together from the best scientists and thinkers alive today about how your mind-body reacts to what you feed it. Before starting Mind and Matter, I spent 10 years in academia doing scientific research. I got a Ph.D. in neuroscience where I focused on neuroendocrinology and the neurobiology of behavior, and before that, I specialized in molecular, developmental, and evolutionary genetics. I use my scientific background to help parse and translate the information that guests share on the podcast. In addition to the podcast, I write long-form written content inspired by the show where I integrate what I've learned across episodes. I also have a free weekly newsletter where I provide you with upcoming guests, share links, and provide commentary on scientific studies and research that I'm reading, and more. Visit mindandmatter.substack.com to find all of my content. Can you start off by just telling everyone a little bit about who you are and what you do?
Sure. So I'm a neurosurgeon. I work at Sunnybrook Health Sciences Center at the University of Toronto. My specialty is something called stereotactic and functional neurosurgery. And I am also a scientist, a senior scientist at Sunnybrook Research Institute, where our group and our interests are in developing new technologies to influence the brain.
So you're a neurosurgeon. You're cutting people's skulls open and doing brain surgery.
You got it. Yeah. Brain surgeon. Yeah.
What do you have a kind of specialty there or a focus area in terms of the types of things that you treat?
Yeah. So I got into neurosurgery because I was really interested in human behavior and really interested in psychiatric disease, actually. So it's interesting because it's a kind of a niche area of neurosurgery using surgical strategies to treat mental health conditions. So, but there is a subset of neurosurgery, a subspecialty of neurosurgery called functional neurosurgery, where the goal is really to treat diseases where you may not necessarily see anything abnormal on a CT scan or an MRI scan, but things are fundamentally wrong with the circuits driving certain behaviors. So typically things like movement disorders, Parkinson's being most common. So movement disorders, pain conditions, epilepsy, and mental health conditions. So again, these are diseases where not always something very obvious on a scan, but something profoundly wrong with patients. And that's those are the kinds of diseases that we treat.
So it sounds like what you're saying is that, we often make a distinction between psychiatric brain issues and neurological brain issues. And to a first approximation, at least, when someone has a psychiatric condition, as you say, there's nothing necessarily wrong with their brain that you can see macroscopically in like a scan. There's not necessarily a big tumor or a chunk of the brain that's malformed or something. There's just functional problems at the level of synapses and cells and stuff in the brain, whereas neurological problems are, more classically associated with surgical intervention. Someone has a tumor pushing against a certain part of the brain. You can go take it out of that part of the brain. What are some examples? What are some of the biggest examples, the most common ways that sort of this approach, the surgical approach, is used to alleviate something that's a psychiatric condition?
So it's a great, you're asking sort of a, really fundamental question about our field, which is, the difference between structural conditions and as you said, functional conditions. For me, as a neurosurgeon and, being interested in sort of where the fields come from, it's really a matter of scale too. So, the tools, you can only see what your tools allow you to see. So, for example, when we did not have any CT scans or MRI scans, about half a century ago, everything we maybe could have considered a functional condition or a structural condition, et cetera. But now that we have CTs and MRI scans, we can probe these things in much more specific ways. And as our ability to establish very fine resolution with MRI scans really improves, we can probe even deeper. So maybe some conditions where in the past we weren't able to see maybe what was structurally wrong, and we just assumed that the brain was structurally normal. It's just a matter of scale and resolution. Now with these fine tools, we can look really finely. So in the psychiatric space, actually, neurosurgeons have been involved very early. In some of the very earliest indications for surgery were psychiatric conditions, mostly mood and anxiety disorders. And this goes back all the way to the 40s and 50s and even earlier, where there was an early recognition dating back really from the 30s that there are important circuits in the brain that govern mood and that govern our ability to make a decision based on emotional feedback. And we've known that. Neurophysiologists have known that from animal models going back again, almost a century now. So the surgical strategies that we developed to treat those essentially tried to sever or influence that circuit in very specific ways. So we know, for example, where mood disorders or where mood in the brain may arise from or is influenced by. And in patients with severe and significant depression, we may influence that in very specific ways. The way that we influence it has evolved hugely in the last 50 or 60 years. But the principle driving that is very similar, which is that, we want to influence that circuitry in a way that influences the behavior. So we have circuits, structural circuits that are driven by biochemical and other factors, but ultimately manifest as behaviors. And to influence the behaviors, you need to influence the circuit.
Mm-hmm. What are some of the more common surgeries that you actually perform on people, and what are you treating with those?
So you can classify the surgeries that we do in functional surgery as what we call ablative, which are precision strike lesions in the brain, permanent lesions in the brain that are able to have circuit-wide, network-wide effects on behaviors. So, for example, we can do a procedure known as a thalamotomy, which is a precision strike lesion in the thalamus that influence things like tremor, essential tremor being the most common condition. You can also use a thalamotomy to treat very troublesome tremor of Parkinson's disease. You can do a procedure known as capsulotomy to treat patients with severe anxiety related to OCD. And we know that you can do that effectively, and the newer tools that we're using can even do it even less invasively than more traditional approaches. Other tools include something called deep brain stimulation, which is a kind of pacemaker. It's a pacemaker for the brain, where electrodes are inserted in specific targets in the brain, and the electrodes are tunneled under the skin to a pacemaker battery that's placed underneath the clavicle, usually on the right side. And the idea is that small doses of electricity generated by the battery will jam the circuitry of the brain. And in a way, you can achieve the same influence on those circuits without making a permanent lesion in the brain, without damaging the brain. You can do it in a kind of reversible fashion. So those two procedures, ablative approaches and stimulation-based approaches, I would say those are the workhorses of our field.
Mm-hmm. And so, of course, these are highly invasive procedures. They're probably things that happen when there's no other options. There's no other treatment that's available for someone. They have to go and talk to a brain surgeon and get cut open, have something installed in the brain, or have part of their brain literally disrupted for therapeutic purposes. You're also involved, it seems, in the development of new technologies that are basically allowing surgeons and scientists to use technologies that have been around for a while to actually modulate brain activity, deliver drugs, do other things in a more non-invasive fashion. Can you talk a little bit about the setup for that stuff?
For sure. Yeah. So, I mean, a big reason why I got into the field is because it's very much, it's evolving. And as we learn more about the circuits of the brain and the tools that we have, the tools that we use today are very different than what we used 10 years ago. And we fully anticipate will be very different a decade from now. So even though the central premise is to influence brain circuitry, how you do that will constantly evolve. So we're actively using something called focused ultrasound, for example. So focused ultrasound is a helmet-like device. And the idea is you use sound waves to influence the brain. And we've been using ultrasound in medicine for decades, for many decades. And in fact, ultrasound is used throughout the body, and everybody knows, that you can use ultrasound in different ways. But the idea is that if you harness the power of ultrasound coming from different sources and focus sound energy onto a very discrete point, you can have very specific biologic effects on tissue. So if you use high frequency ultrasound, you can generate a permanent lesion, just like a magnifying glass harnesses the power of the sun's waves onto a discrete point and generate heat. The same principle applies to ultrasound energy. So we can do this non-invasively. We can focus sound waves through the skull onto discrete points in the brain, guided by an MRI scan, and generate those permanent lesions in the brain to treat patients with tremor and OCD. If you use low frequency ultrasound, you don't generate heat, but what you can do then is temporarily open a kind of window in what we call the blood-brain barrier, which is an invisible to the naked eye barrier that invests the very fine blood vessels of the brain so that you can allow therapies into the brain that ordinarily can't get in. So this is, a real game changer potentially for a lot of diseases where that barrier is a major obstacle. So new techniques for sure.
Okay, so ultrasound, the most familiar use case is, when a pregnant woman goes into the doctor and gets those images of her baby.
Yeah,
So
exactly.
we're using sound waves to generate an image in that case, or in the case you just mentioned, to actually manipulate the brain. So if you use ultra high frequency ultrasound, you've got very, very high frequency sound waves that are being generated. That generates heat, and you can use that and focus it inside different parts of the brain to actually ablate or physically disrupt different parts of the brain.
Yeah, that's exactly right. And when we think about an ultrasound being used to look at babies or looking at maybe our arteries in our neck, that's a single transducer that somebody holds up. So they're holding basically looking at the belly. What we're talking about here is harnessing the power of over 1,000 transducers that emit ultrasound waves, so that we can focus them through the skull. Now, I'm saying it, and it sounds like it's just simple to do, but this has been sort of to be able to focus sound waves through the skull onto the brain has been sort of the holy grail in the field for many decades. So people proposed this back in the 40s. Using ultrasound to influence the brain. But the problem has always been the skull. But ultrasound can't travel through bone very easily. The bone will absorb all of the energy, and you don't get anything on the other side of it. So it required a lot of smart people and a lot of physicists and engineers, and several key people, one of whom is one of my partners here at Sunnybrook, Kalervo Hinanen, who's one of the pioneers of the technology. Requires a lot of people to sort of say, you know what, how can we overcome the so-called bone problem? How can we develop a device? And in this case, it's a helmet-like device that is able to, again, harness the power in a kind of spherical fashion around the patient's head, so that we can get ultrasound through the skull. And that's exactly what we've been able to do for the last 10 or 15 years in patients for different kinds of conditions. So overcoming that was a major physics and engineering problem. And a lot of key advancements had to happen in order to make that happen.
Well, so it's a device. It's like a helmet or a net-like device, and you've got a bunch of little ultrasound probes, and because you've got so many of them pointed at different angles and stuff, that allows you to have quite a bit of spatial precision, I would imagine. What's the spatiotemporal resolution here?
Exactly. We can achieve sub-millimeter accuracy, actually. And the more transducers you have, the more control you have, the more accuracy you have. So initially in the 40s, it was 4 transducer models. And then in the 90s, it was 512. And now it's 1,024. And future iterations will be more and more. So the more ultrasound transducers and sources you have, the more control over spatial and temporal resolution you can get. And also the more so in order to get ultrasound across, you need to use high powers. So, and you divide that. If the denominator is higher, it influences the amount of power that you use. So obviously more transducers, the same amount of power gives you more control.
And so how intensive are these procedures from the patient's perspective? How long does a typical procedure take? Do they have to be anesthetized to be put so that they're still?
Yeah, so it's interesting because one has to sort of have a comparator, of course, and the most common indication for focused ultrasound today is tremor, essential tremor, and thousands of patients around the world have had this done. Now, the standard way of treating patients with tremor, and again, these are patients who have reached the limit of what medical treatments can offer them. So they're all surgical. So considering all the surgical patients, the standard approach is deep brain stimulation. It's the pacemaker approach, where electrodes are inserted in the brain and there's a staged procedure that's done. So compared to that, it's definitely more tolerable. So usually patients are awake during the procedure. There's sometimes an anesthetist or a nurse, administering some small doses of sedation to keep them comfortable, but usually we need them awake because we follow the tremor in real time. So the procedure is done in an MRI scanner. It takes approximately an hour and a half to 2 hours, including the imaging that's done. During the procedure, we use ultrasound to heat the part of the brain responsible for the tremor, and we ask patients how they feel. And one of the key, I would say, value adds of this procedure is that it is done awake, because real estate is everything in the brain. Geography is everything. So immediately adjacent to where we make these lesions are very important structures responsible for motor function and responsible for sensation and things like that. So you don't want to make a permanent lesion in those areas because you get significant side effects.
So the awake patient can give you real-time feedback.
Yeah, they give you feedback, exactly. So they're awake and they can say, oh, when you did that, I felt some numbness in my hand, or I felt a little bit of numbness in my lip. So you know to change the target. We can make millimeter changes to the target and then find the sweet spot and make a permanent lesion.
I see. So it sounds like you can sort of lightly probe the brain so that it's not causing permanent damage to get the exact spot right before you sort of turn up the dial.
Got it. That's exactly right. And we actually call that a sublesional temperature. We can raise tissue temperature to levels where they sort of knock out the neurons in the area, but they don't permanently kill them. And it's a temporary process, and it's you are mapping the brain. So we're mapping, saying, you know what, if I were to make a lesion here, what would it be? And we want to see effect on the tremor in this case and absence of side effects. If we see that, then we can turn up the power.
And so this brings us to another important area, which I think is interesting, which is if you're using the ultrasound at one frequency, you'll heat the brain enough to actually ablate neurons, destroy tissue, which can be beneficial for like the use cases you mentioned. But is there anyone looking into developing sort of the lower frequency ultrasound so that you can actually modulate the activity of neurons in a therapeutic way, where you're not actually destroying neurons, but you're helping circuits become more or less active as a way to functionally correct something?
For sure. I think that it's probably one of the most exciting areas of the field. So two specific areas. There's the using ultrasound to temporarily permeabilize or provide a window into the blood-brain barrier in a safe way. And then there's the neuromodulation approaches. So where you're not opening the blood-brain barrier and you're not lesioning, but you're still influencing the brain circuitry in a meaningful way. Now, there are challenges there. And one is mechanism. What exactly is happening at the neuron, at the synapse, whether it's chemically or whether it's physically or electrically, remains to be seen. And I don't think anybody really knows right now. And I think it's an area of active, really, exciting, but active investigation. The other thing is, the sustainability of the effects. If you are one of the advantages of something like DBS, which we do all the time for patients with movement disorders in psychiatry, is that the stimulation is always there. The battery is providing stimulation all the time. With something like focused ultrasound neuromodulation, you may only be influencing the circuitry when the ultrasound is on. And that may be effective for sure, but we need to figure out how to sustain that effect over a longer period of time. Do you need to sustain it, or do you only need it for some time, some parts of the day or for some parts of the month, et cetera? So I think mechanisms, long-term sustainability, those are the key things that people are actively looking at to see what indications ought to be. But that's the next step for sure. So we're looking at ultrasound across all of these different mechanisms, and there are others. There are at least a dozen different mechanisms, different ways that ultrasound can interact with the brain, and that's definitely some of them.
But it sounds like, as opposed to other ways of doing transcranial stimulation of the brain, which we can do today. In principle, the ultrasound approach offers a much sort of finer scale. It's got a finer spatial and temporal resolution. In principle, you could modulate neurons in very specific parts of the brain in particular ways.
For sure. And when you look at, there are other ways, as you said, ECT, transcranial magnetic stimulation. There's something TACS, alternating current stimulation. So we're in a renaissance right now of brain stimulation, brain technology that is geared to influencing brain circuitry for sure. One of the things with ultrasound that is a value add is the ability to modulate that resolution. So you can look at things like frequency, you can look at amplitude, you can look at pulse width, you can look at all these different parameters to try to fine tune exactly what part of the brain, how deep you want to go, and what you want to target. So ideally, you'd pair it with imaging so that you can see it in real time. But I think as we get better and better at it, and depending on the indication, you may not even need real-time live imaging to do that. You may be able to use the ultrasound and the feedback that you're getting from the device itself in order to target. So I think that's definitely, one of the value adds. And we've had a lot of experience with ultrasound in the brain. We use it still to this day in brain during surgery. Sound waves pass harmlessly through brain tissue. So we know that, standalone is pretty safe.
Mm-hmm. And can you give us a sense of, and I know we're obviously not here yet, but where could this go in terms of, the technology and the application? So for example, is it conceivable that at some point in the future, someone with a psychiatric condition that develops symptoms intermittently, say, they could have an ultrasound helmet at home, and when they need to use it, they sort of just sit in it when their symptoms come on? Or is this something that you think will always be like you have to go into the clinic to do this?
That's the goal. That's the goal for sure. I mean, I think that, we have to assume and ultimately aim for as personalized and comfortable approaches as possible. And yes, having a portable helmet, if you will, or a portable device done obviously under the, guidance of healthcare professionals, that will ultimately be the goal. But I think we have a ways to go. And I think that we're very much figuring out. We have so many levers to press with this technology, and I mentioned just a few of them in terms of the technical parameters. But in terms of indications and in terms of drug delivery, what it is that we want to deliver, where in the brain do we target, and for how long? But yeah, I mean, I think that what you're describing is the ultimate goal. It's highly personalized. It's effective, hopefully. It's safe because we know a lot about this technology. And a lot of diseases are episodic, and they are, things that we just have to get people over the hump. A good example is postpartum depression. We know that this is a debilitating condition. We know a specific period of time that it could develop. Could it be that in conjunction with pharmacologic and psychotherapeutic approaches, you may use something like ultrasound or other forms of stimulation to augment the effects of those treatments?
Yeah.
So I'm a really firm believer in sort of complementary approaches, and and that's how we sort of structured our center, structured our approach. That absolutely, if you have a hammer, everything looks like a nail. But if you have an approach where you're supplementing, just like the same approach we use for cancer, we supplement surgery with radiation and chemotherapy. If you take something as complex as major depression or brain cancer, it's not going to be one treatment. It's not going to be one single approach. It's going to be a complementary approach that's coming at the same disease from multiple different angles. Ultrasound needs to figure out where in that algorithm, what role it's going to play. Okay. It may not be the absolute definitive role, but it may be a central role, a key role that helps improve or enhance or augment other kinds of strategies. And that's really going to be the way we make a difference in these really complex diseases.
Yeah. So it's conceivable that, if you have an episodic condition, especially where the patient can sort of feel ahead of time that something's going awry. Someone, say, has epilepsy, they get that pre-seizure aura. Someone has bipolar disorder, they can sort of feel themselves starting to become manic. You can imagine using something like this to prevent that.
For sure. Migraines is another example. Epilepsy is a great example, which you mentioned. And yeah, I mean, we have conditions like bipolar mania, bipolar depression, depressive episodes where, things, we may be able to anticipate things happening. You may be able to intervene at an earlier stage. So yeah, absolutely. I mean, I think it's aspirationally the goal.
Mm-hmm. And so you mentioned previously that another application here for this technology is to use the relatively low frequency ultrasound to temporarily open up the blood-brain barrier to assist with drug delivery. I want to get into that. Before we get into the nuts and bolts there, I want to paint a picture for people who don't know much about the blood-brain barrier. Can you give us just a sort of simple crash course on how it works?
Yeah, sure. So one can think, our brain is, and spinal cord, but if we talk about our brain, it's what we call an immune privileged organ. So it's an organ that is evolutionarily designed to keep bad things out of it and to allow good things that it needs to flourish and survive into it. And as a result, we have something called we have a physical barrier known as the blood-brain barrier, the BBB. And this is a layer of cells, as well as other kinds of factors that invest the very fine blood vessels of the brain, so that whatever is circulating in the bloodstream, whether it's consumed or injected or what have you, or experienced in the world, it can't get into the brain. So the barrier is a physical barrier. It's a size barrier predominantly. So very large compounds can't get into the brain. Smaller compounds, oxygen, glucose, things like that, some medications can get into the brain because they're designed to be small. They are small. But as soon as you start getting into more designed therapeutics, antibodies, monoclonal antibodies, chemotherapies, growth factors, stem cells, things like that, those are too big. Those are much too big to get into the brain in significant amounts in order to have an influence. The body's own immune system, the body's own immunoglobulins can't get into the brain in significant amounts. And that's why there are some infections that can only occur in the brain because the body kills it everywhere else, but not inside the brain. So it's immune privileged. So we've known this for a very long time. And as a result, we've known that there are some things that, for example, like cancer, that can be relatively well controlled systemically throughout the body, but cannot be controlled intracranially inside the brain. And that's because chemotherapies can't get in. So a way to overcome that has been long sought in our field for many decades, a way to overcome that blood-brain barrier. And many different approaches have been tried. Unfortunately, they've either been too risky or not effective. So ultrasound early on was proposed as a potential strategy to overcome that.
So, okay, so the brain is immune privileged. We don't want anything that's flowing in the blood to get into the brain.
Yeah.
That makes good common sense, I think, to most people. And in essence, if something's small enough, it's got at least a decent chance of getting in the brain. But most things that we might want to put in there, like a medication, are usually too big. So the basic idea is, can we somehow temporarily open up the blood-brain barrier to let things in that we want to get in there, and then it closes back up so that we're not just flooding the brain with anything else that might come after. How is this working now in practice? What is the ultrasound actually doing to achieve the opening?
Yeah. So I would say in the early 2000s, scientists, including Kalerva Hinnanen, who I mentioned at Sunnybrook, began to experiment with ultrasound, low-frequency ultrasound, and microbubbles. So what are microbubbles? So microbubbles are microscopic gas-filled bubbles that exist in contrast agents that we use to image things like the heart and other parts of our body. What we know about microbubbles is that when they absorb energy, they can oscillate. They can vibrate very, very quickly, increase and decrease in size. So what was hypothesized and what has since been borne out in hundreds of animal models is that if you inject microbubbles intravenously, the microbubbles will circulate throughout the body and they'll get to the brain about 30 seconds after they're injected. And if you expose those microbubbles to low frequency ultrasound, the microbubbles will absorb the energy and start oscillating. And when they oscillate very, very quickly, what they'll cause is a physical pulling apart of the cells of the blood-brain barrier. So remember, they exist inside the blood vessels, but the blood vessels themselves will start to separate, and the cells making up the blood-brain barrier will start to separate as long as those microbubbles are exposed to ultrasound. It's a physical process. It's a physical pulling apart of the cells that takes approximately 12 to 24 hours for it to come back and reconstitute. So it was discovered that microbubbles plus low frequency ultrasound leads to a temporary window in the blood-brain barrier in a very focused way to wherever it is that you're directing the ultrasound to. So just like with high frequency ultrasound, we can direct sound waves to discrete parts of the brain. We can do the same thing with low frequency ultrasound. And we can target a brain tumor, or we can target a part of the brain that's important for Parkinson's or for Alzheimer's disease, and temporarily open the blood-brain barrier. And the idea is that if you are also injecting some kind of chemotherapy agent or a nerve or a growth factor or an enzyme or something that you want to deliver, then whatever it is that you're co-circulating will then be exposed to that part of the brain that otherwise it can't get in. So again, temporary permeabilization of the blood-brain barrier is what ultrasound can do.
So literally the blood-brain barrier, you've got cells that are tightly packed together. They've got tight junctions and things physically holding them tight to create that barrier. These microbubbles start to vibrate when you apply the ultrasound after you inject the microbubbles, and they sort of shimmy around such that these cells of the blood-brain barrier temporarily and reversibly start to physically come apart, but all of this is not killing any of the cells or permanently damaging them.
as long as you're very careful about which ultrasound parameters you use. So it was very early recognized that, yeah, if you use too many microbubbles, if you apply too much energy, if you leave ultrasound on for too long, et cetera, in other words, if there are no redundancy mechanisms or safety mechanisms in place, you can cause damage for sure. And you can cause something called uncontrolled inertial cavitation, which is basically a collapse of the blood vessels. And if you have a collapsed blood vessel, you can potentially get bleeding and swelling, which are the two things we worry about. So this is not this is a very fine process, a very, by definition, a microscopic process, but it's one that requires really fine level of control. And when we started doing this, and when the device was starting to be designed, a fundamental component were these safety and risk mitigation strategies. So this being ultrasound, we can build in what's called hydrophones into the system that listen to feedback from the ultrasound and from the microbubbles themselves, so that if there is any sense that cavitation is happening or that anything untoward or risky is happening, the system shuts off. So there are sort of these risk mitigation strategies in place. But it's important to remember for sure that, when we're influencing the blood-brain barrier, it's important that, it be done in a sort of judicious way. And that's, again, one of those things that we're actively looking into. What parameters can we use to modulate how much of the blood-brain barrier is open, and how big is that opening, and how temporary is it, and how long does it last?
And so what are some examples of this technology in use? What kinds of drugs are you able to get into the brain, and for what purpose?
Yeah. So the first trial that we did was in glioblastoma. So glioblastoma is a malignant, aggressive form of brain tumor, stage 4. It's a grade 4 brain tumor. And unfortunately, despite rapid advances in our ability to recognize the disease and study it genetically, not a huge amount of we haven't been able to really move the dial on treatments for the disease. But before we got to delivering a therapy, and I'll get to that in a sec, before we got to that, we wanted to show that it was safe to open the blood-brain barrier in the first place. And that's because of exactly what you mentioned, that we're opening very fine blood vessels. We want to make sure that we can actually do that safely, and that it was technically possible to do that. So the first patients were in glioblastoma, where we just opened the blood-brain barrier without delivering a therapeutic. And we were able to show that now almost a decade ago, that in patients who had previously undergone surgery, previously undergone radiation, we can safely open the blood-brain barrier, and we can do it reversibly. So after that, we designed a trial looking at the delivery of something called temozolomide, which is an oral chemotherapy agent that is administered to patients with GBM, standard of care. And the idea there was to couple that with ultrasound BBB opening. And we did, in fact, show that it was safe to do that. We've gone on to delivering monoclonal antibodies, which are very large compounds, to treat patients with breast cancer metastases to the brain, as well as doxorubicin, which is a chemotherapy agent used to treat things like sarcomas, but hasn't been used to treat brain cancer. But we're using it to see if we can improve its delivery in pediatric brain cancer as well. So those are the chemotherapies, and we're interested also in antibodies and enzymes for Alzheimer's disease and Parkinson's. So in all these instances, very large compounds where in the past there may have been a rationale, but the blood-brain barrier was a major obstacle.
One thing I want to ask you about that's also interesting, it's a little tangential, I think, but what we're talking about here, we're implicitly talking about people who have a blood-brain barrier that works, that has high integrity, that needs to be open because it's not normally permeable to these things. A lot of people, my understanding is over time for different reasons, and I'm not sure how much we know about why this happens, but the blood-brain barrier can lose its integrity over time. It can become leaky. Can you talk a little bit about what we know in terms of how often that happens and why it happens?
It happens a lot. And in fact, some of the theories behind Alzheimer's disease is relating to leaky BBB. And also we know in brain cancer, the reason we can see tumors on an MRI scan is because the blood-brain barrier has been compromised, and gadolinium, which is a contrast agent that we use, is able to seep in. And gadolinium is twice as big as a typical compound that can get across normally. So the BBB is abnormal in many of these patients. But what we also recognize and believe is that it's abnormal in abnormal ways. So there's been a breakdown in the normal machinery. So there's a very different morphologically, physically, electrically. The blood-brain barrier in a healthy person, if you will, in an uncompromised state, is different than in somebody that has a compromised blood-brain barrier. Some of the cells have broken down, the tight junctions aren't as strong. And we know that the mechanisms and sort of the more practical aspects of opening the BBB are very different in those populations. And as a result, when we target, for example, a brain tumor, we target beyond the edge of what we can see on a contrast enhancing scan. We know that in those parts of the brain, a centimeter or two beyond what we can see or beyond what was resected, that's where most of the recurrences will occur. That's where brain tumor cells live. And we know the blood-brain barrier is more intact in those areas. So that's the rationale for doing that. Certainly in conditions like Alzheimer's, we're just learning. We're learning that amyloid itself can render some of the can have an impact on amyloid and tau can have an impact on the blood-brain barrier. And the goal really is to impact intact, healthier blood-brain barrier than one that has already been compromised. Really, the analogy that I often use is an out of control sort of fire versus a controlled burn kind of thing. And with FUS and BBB opening, that is done in a very controlled fashion, it's more of a controlled burn. The idea is you're able to control the parameters and you recognize the anatomy is more healthy or more normal, rather than a situation where it's uncontrolled and some of the basic mechanisms, the blood vessels may be leaky, it may not be as effective. And it may be that FUS may not be as effective in those populations.
Is there much thinking or even evidence that certain brain disorders might be downstream of a leaky blood-brain barrier? Is there anything, whether it's Alzheimer's or something neurodegenerative, are some of these things potentially caused by the leaky blood-brain barrier enabling toxins or other things, inflammatory molecules to get into the brain and then trigger the disorder?
Yeah, it's a great question. For sure, the neurodegenerative conditions are, high up there in Alzheimer's. I mean, I think the field of BBB and Alzheimer's is really active right now. I don't think there are any clear answers. What we know is that there may be an issue with drainage away from the brain. So there's an intense area known as lymphatics, which is an area of research that is really interesting in the neurodegenerative conditions and Alzheimer's specifically, which is how is waste drained from the brain, for example? How is blood flow moving away from the brain to carry all these toxic proteins and toxic collections away from the brain in a normal state, and how is it gummed up in an abnormal state? One of the interesting things that we've shown is that when you open the blood-brain barrier, you sort of see a enhancement and you see increased drainage around the very fine venules and blood vessels of the brain, which for us was the first time that you can actually potentially visualize that glymphatic system that has only been theoretically posed in the past. So here, because you're kind of, again, in a controlled burn kind of fashion, opening these very fine blood vessels, these capillaries, we've never really been able to visualize after you inject contrast, how is contrast then seeped away from the brain? Well, we think it's now happening around the blood vessels, around these venules, and that may be a mechanism that things are drained away from the brain. And as a result, a failure to do that may be linked to some of the neurodegenerative conditions. Again, very early days, but I think an area that is really quite interesting for us to study, but also I think maybe linked to some of the pathology.
How much do we know about factors that lead to a leaky blood-brain barrier, whether that's lifestyle factors related to things like activity levels and sleep quality, whether that's things like drugs that people might take for other reasons, then have a side effect of affecting the blood-brain barrier? Are there any patterns that we see clearly that lead to leaky blood-brain barrier?
To be honest, I think we're quite early in this area. I think we've been hampered by, frankly, our inability to visualize what's happening on a real-time basis. We know that sleep modulates BBB function for sure. We know that aging does. We know that exercise and cardiovascular health and even sedentary lifestyle influence for sure the development of dementia and Alzheimer's, but it's linked to BBB, I think remains to be seen. we know from neoplastic and oncologic conditions that it's intact in most patients, except around the area of the tumor. And there are also regions of the brain that that lack a blood-brain barrier, the pituitary and other regions of the brain. So I think that's where a lot of insights will come from. But it's very much early days. But again, going back to the very first question about scale, about, maybe we just don't have the right tool to look at this. I think that we're just at the point where we're looking at ultrasound as a therapeutic strategy. But what may be really cool is looking at it as a kind of diagnostic strategy to look at, well, what is the integrity of the BBB in these different conditions and how can we modulate that potential?
Mm-hmm. And when we think about the use and the future use of ultrasound technologies in the ways that you've been describing, and we think of even future states where people have portable devices they might be using under guidance from their own homes, can you give us a sense for the costs here? How much does it cost to create some of this physical technology, and how much does it cost to actually use it?
Yeah, it's expensive. So currently, it can only be done, or it should only be done, really, in centers that have an MR, like a dedicated MRI capability, because it's an image-guided procedure. So there's obviously the millions of dollars that you need to invest in an MRI and somebody to run the MR and a facility. The device itself, and we work very closely with our industry partner, Insight Tech, which is the leading manufacturer of FUS technology these days, certainly in the world of tremor. So yeah, these are devices that cost millions of dollars, and that's just the upfront. Then you have the upkeep. You have to make sure that you have the latest tools, the latest technology, software and hardware, and that you're able to maintain them. Arguably, some of the most expensive and rare resources are the people. So these procedures require a physicist, require technicians, and require clinicians to do, and not just the treatment. To say nothing about all the upfront work to select patients who ought to get the procedure, who's going to follow the patient afterwards. How do we assess somebody that, for example, has failed and then needs to be retreated? So all of these costs need to be factored into it. Can we get to the point where certainly for the BBB strategies or the neuromodulation strategies, we're looking at more transient, temporary treatments for sure. And as we do that, the cost will definitely shrink. But what we need is an indication, and what we need to show that it's safe and effective first for an indication before we get there.
Mm-hmm. And so can you sort of paint a picture of where the cutting edge is today in terms of, what are some of the studies that you've recently done that are published, or some of the things that are pre-publication? Where's the cutting edge here?
Yeah. So, it's rapidly advancing. Mm-hmm. So I think that, if we're talking about the lesional side, so precision strike lesions, I think we have an opportunity to essentially make lesions currently, and I anticipate within the next 3 to 5 years, anywhere within the brain. Right now, we're fairly limited to the geometric center of the brain. And that's because, again, the further out you get from the geometric center, the more transducers that we discussed actually need to be shut off because they're too far away from the target. Mm. And when you shut off a transducer, you reduce the power and you can't make a lesion. So we're really focused on the center of the brain. Within the next few years, that geographic limitation is going to be eliminated. So that means conditions like epilepsy, like pain, psychiatric conditions, and movement disorders. The goal is ultimately obviating the need for any open neurosurgical approach. So we just published a couple of weeks ago our experience in OCD. So long-term follow-up in our patients that we treated with capsulotomy, so precision strike lesions in the region of the brain known as the anterior limb of the internal capsule in patients with OCD, showing that in these patients who are truly resistant to treatment refractory, we saw very favorable response rates at a year, about 50%. So 50% of patients had significant improvements in their anxiety, having previously failed previous treatments. So that for us was, critical goal, but also a critical moment in the field where we may be able to offer this treatment to patients with treatment-resistant anxiety. As the technology improves, we'll be able to do that more and more. On sort of the non-ablative BBB side, one of the most exciting things that we're doing now isn't necessarily showing that we can get things into the brain, and that work is happening. But we're also interested in seeing what can come out of the brain after we open the blood-brain barrier. That's because we know that the BBB is a two-directional street. Not only does it prevent things from getting in, but it prevents things from getting out. So if you open the blood-brain barrier around a brain tumor, Our question is, can you then detect very fine fragments of that tumor in the bloodstream after you open the blood-brain barrier
For diagnostic purposes, say?
to make a diagnosis? Exactly.
Yeah,
So patient comes with a brain lesion, you expose it to ultrasound, open the blood-brain barrier, do a blood test, and maybe you'll be able to make a diagnosis. So we're doing that for things like lung cancer and other conditions. It's called liquid biopsy, but liquid biopsy approaches in the brain have been limited by the BBB. So here's another potential diagnostic opportunity that we can use. And ultimately, neuromodulation is going to be probably the future of this technology, and we're going to see that really coming fast in the next decade or so.
And you mentioned some of the spatial limitations here, and how that connects to, the physics of how this works. We're limited today to, certain parts of the brain, but eventually we'll be able to do the whole brain. Of course, there's a lot of creatures out there with much smaller bodies and brains than us. How is this technology being used for things like basic research?
It's I often say that I'm not aware, having been in the field now of neuromodulation for 15 years plus. This is probably one of the most preclinically studied tools that we have, which is to say that hundreds of animal studies have been done using ultrasound before we actually made the leap to go to humans. So ultrasound studies are being done in basically every animal model you can think of, from small animals, rats and mice, to rabbits, and all the way up to non-human primates. So the work is ongoing, and obviously, the closer the brain resembles ours, the broader conclusions we can make. But on a very mechanistic level, especially the work related to neuromodulation and BBB opening, we need to know and we need to fine tune the parameters of ultrasound before we apply them to human populations. And the question you asked about safety earlier, can we cause damage? I mean, those are very important questions, and we need to elucidate that in animal models before we translate that to human populations. It so happens that we can very readily translate, and that ultrasound is being used all the time in animal models, and some of the most exciting applications of drug delivery and things like brain injury and stroke are happening now in animal models.
Yeah, I would imagine you might want to very quickly get something in the brain if someone has a stroke, say, that is going to reduce inflammation or something like that.
Exactly. And we know that when somebody does have a stroke, there exists cells, neurons in the penumbra, which is what we call the region of brain that is still salvageable, provided that reperfusion is established quickly. So it could be that those cells are sort of tenuous, and that just a little bit longer being deprived of oxygen, they'll die, but they're still tenuous. They're still in that range where we can survive. If you can deliver growth factors, if you can deliver neurotrophins, if you can deliver different things to those cells, you may be able to have a neuroprotective effect. And similarly in trauma, brain trauma.
And so it sounds like this is a very fast-paced field, but it's probably going to be decades in the making of improving the technology, having more widespread applications, and really sort of figuring out how to use this for many use cases.
Exactly. I think it's an exciting time to be in this field, but I think it's still hard to wrap one's head around what the potential could be. I think that it's growing for sure, and it's growing exponentially, and we've shown that. But I think what this ultimately looks like will be guided by the questions and the indications that we're investigating. But you're right. I think it's a decades-long process, but it's an exciting opportunity. That we have. We're already influencing and changing people's lives, which is terrific with the work that we're doing in tremor and OCD and some of the movement disorders. But we haven't really scratched the surface of what this technology can do, and I think it's an exciting opportunity in time.
And what would you say is sort of the rate limiting part for just progress in this general area? Is it the physics behind developing the technologies that'll give you, better devices that have better resolution and more your ability to use them more finely? Or is it more on the medical and treatment side, figuring out how to safely use this technology? What sort of is there one of them clearly limiting here?
Yeah. It's something that's very boring and it's regulatory, I think. There are incredibly smart people working in the ultrasound field, and I would say that will continue. There's a huge influx of engineers and physicists and companies in the space, and that will only grow. there's no lack of will. There are patients with these dreadful conditions that we want to influence, and no lack of ideas.
Hmm.
What we want to do is establish a kind of pathway, whether it's at a local hospital level, local research institute level, or at a government level, whether it's Health Canada in our jurisdiction, the FDA, the Ministry of Health, in order to create processes where we can rapidly translate exciting advances in the biotech space to human populations in clinical trials. And that's not to say that we should cut any corners in a scientific or ethical or moral way. Is just reduce the red tape and allow us to do the trials that we need to establish whether, in fact, this technology has legs and is safe and effective. So I would say that, a large majority of the time that we spend on research is regulatory. It's getting things approved. It's working with our local ethics boards and working with our ministries in order to get these trials going. Necessary, of course, and nobody's arguing that it's not, but I think that lots of efficiencies can be found, and I think will really accelerate the field.
Mm-hmm. Can you maybe give us a little bit more of a concrete sense of what that's like when you say things like red tape? Is it just that there's many different layers of approval you need every step of the way?
Yeah, exactly. I mean, I think that there, naturally a lot of agencies, whether again, local, federal, provincial, are overwhelmed. And I think there are a lot of interesting ideas and a lot of things happening. And we're very motivated to move things forward. And sometimes it can take months or longer or years to get things going, to get a trial off the ground, even a condition such as ALS or glioblastoma, ones where there is a lot of therapeutic nihilism in the field, which is that, there are no treatments available. These patients, unfortunately, are going to pass away from their diseases. We need pathways to rapidly translate really exciting advances in the field in a safe, responsible, judicious way to patients as quickly as possible. And that's what we're really motivated in doing. But sometimes that process can take weeks, months, and unfortunately years.
Well, I mean, what do you think it should look like in principle? Like, could you have a process in place that enables you to move at the scale of days, but still do it and check all the safety boxes?
Yeah, I mean, look at what how the world mobilized to get us a COVID vaccine. And, in less than a year, we went through all of the stages that we would need to do to go through the trial, the science, and ultimately regulatory approval of a vaccine that was administered the goal was to be administered to the entire human population. So it's there. The will just has to be there. But I think there needs to be sort of a high throughput, high yield, high impact process that is probably reserved for high risk, high reward trials that is focused on getting these things especially for diseases that are terminal and ones where there are very few effective treatments, to get trials going as fast as possible. And that's, we try to live by that philosophy at Sunnybrook, where I work, in the center, the Harkwell Center, where a lot of the trials are happening. We believe strongly in what I call a kind of progress in parallel approach, which is that we have multiple trials across multiple indications because we just don't know which ones will work. But if we were to stay with just one track and one disease, one trial, wait to see if it works, if it doesn't, fine tune it, and then move on to another one, it's going to take us decades to have any impact.
You need to parallel process.
You need to parallel process. That's the only way. But right now, regulatory authorities are often serial processing. So what we need is a parallel approach. And that's how the dial is going to be moved. There's no question. And it won't until then.
What would be required to achieve that in principle? Like, would there need to be just a very significant restructuring of the regulatory apparatus itself?
Yeah, I think so. I think you need to sort of overhaul the process for sure. I mean, we hate to sound like a consultant, but we need to find efficiencies in the system where maybe we can improve things. It needs investment. It needs investment in infrastructure, investment in people, investment in ideas. And it starts at the very top. I mean, it starts at government and then it percolates down to the more local, provincial, municipal and hospital level. But yes, it requires the push and onus to be there, and ultimately probably comes down to funding and money and how we structure things. Mm-hmm. It's what we want to be known. It's what we want to be known for. I mean, Canada has hit way above its weight. Its weight class in terms of innovation, in terms of the biotech space, in terms of developing world-changing technologies. So here we have these kinds of technologies and opportunities, and we need to keep it. We need to keep it that way. We need to reinvest in it. So we can't sit idly by while these diseases are rampaging through the population.
Mm-hmm. I want to ask you some more personal, professional questions, and then give you some time back because you're going right to see patients after this. Just for everyone listening, what do you love most about being a neurosurgeon? What's your favorite part, just in terms of the emotional enjoyment you get?
Yeah, it's a great question, which I reflect on a lot because the other hat that I wear, I oversee the training program of neurosurgery at the University of Toronto. So I speak to a lot of medical students interested in neurosurgery and residents as well. So lots of opportunities to think about it. But at the end of the day, it's the interaction in the office with patients. Oftentimes neurosurgeons see people in the most difficult times of their lives, dealing with truly dreadful diseases, whether it's cancer or trauma or other kinds of conditions. The trust that patients put in me and our team is second to none. The reward that comes with seeing patients through a very difficult time, seeing them in follow-up, seeing how they're doing, is absolutely the driving force of what I do. Now, the homologue of that and the corollary of that is the opposite, which is, we also see some very devastating things in our field, but that's where I get a lot of solace from the research and the scholarship that we're trying to do and the advancements. So you have the highs of neurosurgery and the lows we try to supplement with our relentless drive to try to improve the outcome. So it's a fascinating field. There's nothing more interesting than the brain. There's nothing more interesting than our ability to move around the world and interact with each other, and we have a front row seat of that in neurosurgery.
A dual question for you: what's the most difficult and what's the most frustrating part of this profession? And the distinction there in my mind is, when I say difficult, I mean what's the hardest thing to do in terms of effort and the level of concentration needed to complete that part of the job, versus frustration, which would be, what do you have to deal with that's just the most unfortunate and frustrating thing?
Yeah, I would say difficult. It's interesting because it depends on the stage of your career. I would say that yes, the surgeries are arduous, can be long, can be physically draining. But what I tell trainees and others is our field is physically demanding. It can be emotionally demanding, but it can also be spiritually demanding. It can also impact you on a much deeper level. No question, the most difficult part is breaking bad news, and is telling a family member or a patient either a dreadful diagnosis or when things maybe don't go as well at surgery as we hoped, and complications happen, and they do. They happen to every surgeon. They happen to every specialty. But when things don't go as you had planned, for sure, that's the most complicated. That's the most difficult. Frustrating. It's boring, but it's probably paperwork, administration. It's the things that that are necessary to do to run an office, a practice, and a laboratory. But where you want to be efficient, and maybe you're not as efficient as you wish to be because of those things.
Mm-hmm. And how many? I'm just out of curiosity. How often are you doing surgeries? Is this every week? Is this every month?
It depends. So I have a very busy emergency practice. So I would say that I'm in the operating room anywhere between 3 to 5 times a week. Now, we have elective time that every neurosurgeon has, and that's once or twice a week. And then we also do very frequent overnight call. And Sunnybrook is a level 1 trauma center. It's actually the biggest and busiest trauma center in Canada. So we see a lot of head trauma. So I would say on an average week, I'm in the OR anywhere between 3 to 5 times. And often it's after hours, at night, et cetera. So it can be a long wait.
Mm-hmm. At what point in the educational process in your career, what was it like to do sort of the first surgery where you really had the responsibility for the patient and you weren't under direct supervision, say by a mentor or something?
Yeah, I remember it very clear as day. I mean, I think it was summer of 2016 or 2017 when I started at Sunnybrook. And you do feel like the training wheels are off for sure. I mean, these are patients that you saw, these are patients that you consented, patients that you take full responsibility for, that you see in follow-up. But I can tell you this, that we have gone through so much training by that point, that, that any trepidation you feel is quickly eclipsed by eagerness, and enthusiasm to do it. And you sort of, so my residency was almost 10 years. I did residency and then I did a PhD during my training and then a fellowship afterwards. So I was very eager and ready to take that on, to finally take on that responsibility. And maybe it's by design. Maybe we make neurosurgery training so long that, we're so eager to get started at the end. But I would say that, we train people very, very well at U of T and across Canada. Neurosurgeons are trained exceptionally well. That they're more than ready for that when the time comes.
And what type of, is there like a type of person that's well suited to become a surgeon or not well suited? And what I'm thinking here is, like, a lot of people go into college, they go into medical school. It's very, very common across many fields for, X number of people to go in thinking they want to do one thing, but then once they start down this path, they quickly realize, oh, I'm not well suited because I've got this type of personality, or I'm not good with my hands or whatever. But what are some of the qualities besides the training per se that make a good and enthusiastic surgeon?
I think it's evolving. I mean, I think it was very different, I would say, in the 70s and 80s, where one had to you had to, in many ways, be prepared to marry your specialty at the expense of everything else. So the expectation was you are a surgeon first, and everything else is sort of by the wayside, including many of the things that we value, like your family and balance and things like that. It's very much changing. And in neurosurgery in particular. So, for example, I was going to do psychiatry for the first 2 years of residency. I did a psychology undergrad, and then I was going to do psychiatry. But then I realized during medical school that there's really cool work happening in neurosurgery and psychiatry. So I pivoted and became a neurosurgeon to be, to do that kind of work. And I am. I would say that the overarching qualities that really make an excellent surgeon is somebody that is a finisher, somebody that is as a can-do kind of attitude, that, they're, for lack of a better word, that has grit, somebody that has that resilience, and is able to bounce back, and, especially from deficits and from difficult times. Somebody that's compassionate, and can balance the technical demands with looking after patients, even though this is the thing a lot of medical students don't really see until they're residents or until they're faculty, that yes, I'm a surgeon, but I spend the majority of my time in clinic, and I spend the majority of my time on the ward or in the intensive care unit or in the emergency room. It's not in the operating room. We do surgeries, but we spend much more of our time seeing patients before surgery and seeing patients after surgery. So one has to enjoy speaking to patients and having that experience and guiding them through. So definitely resilience, compassion, curiosity, I would say, is absolutely needed in abundance, especially in a field like neurosurgery, where we're confronted with so much negative stuff that you need to be curious about how to improve that over time. But we're very proud we can train people that have those skills to be outstanding neurosurgeons throughout Canada.
Is there anything you want to reiterate, or any final thoughts you want to leave people with to do with anything we spoke about today?
No, I mean, I think you touched on everything, and it's an exciting time to be in neuroscience and to do neurosurgery, and just thrilled to be a part of it. Even though you hear my voice, what you don't see is the iceberg beneath the surface, which is the huge team I have the great privilege of working on at Sunnybrook, and the tremendous networks that we have. So whether it's ultrasound or brain stimulation, I'm very lucky to work with the team that I do at Sunnybrook, and to have their support. So no, thanks very much.
All right, Dr. Nir Lipsman, thank you for your time very much. Very busy guy, but this is fascinating stuff, and I think a lot of people are gonna enjoy listening to this.
Thank you so much.